Thank you all for coming through. A few more than maybe I expected, but a few faces I didn't expect and a few people that may have missed the reminder, which is absolutely fine. Tonight we're talking a little bit more about chronic pain with our pain patients generally, because it's a really big difference there, and I know quite a few of us really struggle with that as well. So I really wanted to go through in a bit more depth on that side. I've met a lot of you previously, and good to see you all again. Basically, I am Kent Hungerford. I'm a specialist podiatric surgeon, having done my undergraduate through La Trobe University and my postgraduate doctoral studies in surgery through the University of Western Australia. I run a few different styles of clinics through here, but basically I'm maybe doing 5% of what we call general care, so nails and skin care, probably about 60% into chronic pain management, and within that, you know, the rest would be sort of that minimally invasive reconstructive foot surgery. I do have a select few patients within that surgical side that are also into our private high-risk foot / ulcer management clinic as well. And so if you're getting caught out with the public system, as I was talking to some of the ladies here about earlier, you know, sometimes it can take a little bit longer. I'm more than happy to see them, of course, to try and get some of those interventions into place sooner. Having had a bit of a background in the high-risk foot clinics locally and back in Western Australia too. But tonight, really about that chronic pain side. And bathroom, for those that didn't hear, sort of on this corridor, first door on the right. Food and drink, please get up and grab some extra food and drink throughout the night. I'm a pretty cruisy guy. For those that haven't met me, please yell out your questions. They're all going to value add to this evening, and I do want a little bit of chat that way. I've already mentioned the recordings happening, and we've already done a bit of it about me. Anyone have any questions about me? Excellent. Tonight we're going to go through a bit of pain theory, because I think it's something that's really undercooked a lot of the time in our undergraduate podiatry courses, because there is so much to cover, obviously. Physios, sorry, I hope I'm not covering stuff that you've already been very aware of, but definitely a lot that way. And then going into some of the interventions and how I use those and how I sort of look at these to really start getting a bit of an idea of, okay, what can you be potentially putting into place as well? And there's a lot of hints, tips and tricks along the way that hopefully you'll pick up and find quite valuable from that perspective, through our prolotherapy and injection type therapy, our strength and conditioning, our proprioception retraining, which is a huge part of pain management from my perspective, a bit more on our psychosocial approaches, and then I'm going to finish up with the what's next and the sneak peek at Relieve Health Group. For those you know, unaware, we did sort of rebrand to Relieve Health Group, which does incorporate South Coast Foot Surgery, Relieve Podiatry, Relieve Pain and My Health Education. And definitely, and I'll push it at the end, jump on our YouTube, our Facebook, our Instagram, because there's some really cool stuff coming through as well, not only for you as practitioners, but also for patients. And I will touch on that a bit more later. So let's go into a bit more about pain, jumping straight in the evening. In, I think it was 2016, they changed the definition of pain to an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now that's a really big shift. Think about that a little bit further with regards to, you know, that actual or potential damage. And we do know, okay, well that makes sense. But previously it was all about physical damage. It didn't leave any room for any of the psychological or psychosocial aspects that can be leading to pain. So we're really changing that approach of actually pain doesn't have to be physical in any way. Now we all know this, you know, heartbreak, nerve pain can sometimes be exactly that without a traumatic incident. So consider that pain is broken down into the two broad categories. We're looking at that nociceptive pain, and that arises from the actual or threatened damage to non-neural tissues, so plantar fascia, for instance, or the Achilles tendon, and it's due to the activation of the nociceptors. In contrast, neuropathic pain is that caused by a lesion or disease of that somatosensory nervous system. So pain versus nociception, and I wanted to really cover this off because this is something that's not necessarily understood as well. So remember that actual or potential tissue damage that I mentioned earlier in that definition. That pain is the perception or conscious awareness of the nociception. Okay, we experience pain, we don't necessarily feel pain. So when you stub your toe in the bedroom versus on a busy road is very different. Now let's have a bit of a look at that example. If you're running across a road on a busy highway and you stub your toe, it's going to be bleeding, it's going to be looking awful after you get there, but your adrenaline, your body's basically saying, no, there's something more important right now. I'm going to get across this road and then I'll worry about that there's actually pain, trauma, and damage to that toe. In the meantime, you stub your toe on that bedside cabinet and we all know about it, definitely. And this is how our body upregulates or downregulates that nociception, which we then experience as pain. And I wanted to go through a few of those theories with you today on what we're looking at. But how do we talk about pain with our patients? We need to categorize that pain intensity, and I sort of talk about that within 3 dimensions. One is going to be the pain intensity. That's typically going to be our very standard VAS. I am in this much pain, 8 out of 10 as it may be. Then we talk about our pain related to stress, bringing in a bit of a psychological aspect, and then we talk about our functional impairment, talking about our social aspects, you know, and then we want to get a bit of an idea and rate these as far as what the patient feels may be the level of impact on their activities, on their life, throughout these 3 domains. And I think it's a really nice way, even if we're not actually verbally talking about this with our patients, to actually start considering these things and going, okay, what are we looking at? How much is it potentially impacting their work? How much distress do they have from this? Particularly people that are in high distress and quite wound up, we all know they're going to have higher pain levels. Does anyone use or look at these type of aspects and domains? Yeah, even if it's a little bit more subconscious, most of us would be. Because when we start talking about particular things, one of the common things that I see, particularly at the moment, and I know everyone that sees patients with diabetes, is that plantar foot burning related to, say, a tarsal tunnel syndrome or any other concern like diabetes. They're characterising their pain intensity as 6 out of 10, which is reasonably severe, but their distress is potentially going to increase that pain level up to that 8 out of 10. Their actual functional impairment is the 4 out of 10. So they're fearing that they might miss work, but they're not necessarily missing it. They're fearing that they might be under some financial stress because their family is really dependent on them working. Now, all of a sudden, that actual functional impairment of a 4 out of 10 very much brings the pain up to an 8 out of 10. And where we can manage that pain-related distress by saying, actually you're working all right, let's talk to management, let's go that way, let's have a bit of a look at other things that we can make sure that we're going to reduce our risk overall with regards to increasing it by decreasing the distress. And in that way, reducing our pain levels. But there's a few different ways that we can look at this. Has anyone heard of these ones? I'm hoping a few do. I know Ellen's all over this sort of stuff as well. Central sensitization, peripheral sensitization, gate control theory, and biopsychosocial model of pain. That biopsychosocial model of pain is really the current approach to pain management. We're all probably practicing it, but it's great to have that reminder. For those that are unsure, you're going to be getting an email, and I appreciate if you've left your direct emails out there, to be able to look at these in a little bit more depth through some other lectures that I've provided, and they'll be coming through to you in the next week as well. But let's just go through really briefly on these ones. So when we're talking about central sensitization, we're talking about those amplified responses, okay? It's the nervous system exaggerating the response to stimuli, even non-painful ones, okay? That might be that light touch that we're talking about, that people are very hypersensitive. We then have that lower pain threshold, the increased sensitivity to pain leading to pain with just a very small stimuli or input. That persistent pain, so the pain signals are going to keep repeating even after that initial injury or the stimuli is removed. That's where we're going to be seeing potential ongoing concerns and pain. but really the neuroplastic changes, how that brain's going to be then changing. And we do see this quite a lot, and this is the stuff that I'm really interested in because it brings in that psychological side as well. Those alterations in the nerve pathways which enhance the pain transmission and the perception as well. Bring it back to peripheral sensitization, we've got that enhanced sensitivity. The peripheral nerves become more sensitive to stimuli, including the touch and pressure. They give increased pain signals, so the nerves send amplified pain messages to the spinal cord and the brain. The inflammation, and this is one of the real cruxes for peripheral sensitization, is that it's really inflammatory mediated. There's a lot of chemical mediators that are aggravating those nerve endings, which are going to intensify the pain, create that the action potential to be occurring more often and at that lower threshold that we're looking at there. And then it provides that altered response. So normal sensations may trigger pain, leading to hypersensitivity in the affected areas. Now you're saying, gosh, they sound pretty similar, and you'd be right, and you can suffer from both. When we're looking at that central sensitization, it's really amplifying that signal with the lower pain threshold, whereas the peripheral sensitization increases the sensitivity of the nerves due to that chemical change that's happening locally in that area. Now there's things that we can do to sort of push that in the right direction and really make sure that we're doing the best by reducing this pain. And I think it's really, a lot of our patients come through with these type of pains, and I know myself, after my undergraduate, I had no idea about these, but I was seeing this and I couldn't really explain it. And so this is where these type of conditions do come in, or elements of their actual physical conditions can amplify that pain. Any questions on those ones? Excellent. We then talk about a gait control theory. Now this is relatively disproven, but it's a really nice way to sort of explain the upregulation and downregulation of pain. And it's all really happening within that spinal cord, where it proposes that there's actually a gait. And that's going to modulate how much pain or nociception is going to the brain that we then perceive as pain. Too many AINs on the end of those words. But really we're looking at that input control. So a non-painful stimuli can actually close the gate, inhibiting pain transmission. These are things like good thoughts, pain perception. Pain signals are regulated by the balance of those inputs from the nociceptors and other sensory fibers as well. But then we've got those psychological factors, our emotions, how much we're paying attention to that, or maybe we're paying attention to that truck that's coming down the road, which we don't actually have in our bedroom. The expectations of how much pain you should be in. We all know that as long as you don't look at it, it's not going to be too painful. That's a big part of what we're talking about here. And they all influence the gate opening or closing, which is going to affect actually how much pain we might experience in the end. I think it's a really nice way to explain with patients of just saying, basically, what you're doing, what you're thinking, how you're going about it, and your previous experiences of pain are what's going to define how much pain that you're going to be in. Now, the biopsychosocial model. Have people heard of this? A little bit of a raised hand. Yep, beautiful. It's a really nice model because it really allows you to then start embracing what we're looking at. Now, within our podiatry, physio side, and I don't think we've got anyone outside of those two professions tonight, that we can start looking at that multifaceted approach, really making sure that we're not just focusing on the biological aspect and really bringing everything in to make sure that that pain's going to be reduced. But it comes in a really nice ways that we're probably already doing, even if we had no awareness of this model. That it does consider the biological, the psychological and social factors. It really looks at the physiological process, such as that nociception, such as the central sensitization, the psychological, focusing on our emotions, our beliefs, our coping strategies, and the social, so cultural aspects, environmental and social influences on that pain perception, and then longer term that pain management as well. Now, I'm a big one for patient education. That's a big part of why you're here tonight and why this is going to be available for free, not only for you guys, but for patients as well. And our longer term model is to be able to have patients being able to look at this even from your own clinics, so that they can get a bit of an idea without necessarily everyone having to do the same thing. Because they should understand pain, because understanding is going to lead to reductions in pain as well. But this means that we need to be educating them. It means that we need to be talking more than just that physiological or the biological. We need to consider that pain is something else as well. Now, how are we potentially going to be looking at this? Now, there's all these different verbal cues that we can give as well. And I do want to sort of talk about that with regards to this, because as soon as we say, oh, your pain's not that bad, and actually your ultrasound's pretty good, they stand up again and they say, oh, their pain's pretty good. You know, as soon as a patient's coming in to see us, you know, daily we hear, oh, the last couple of days my pain's been pretty good actually, because they're coming to see a professional that they've already got trust in before they even come through the door. 2-3 days out, they're starting to feel that benefit from knowing they're going to see you. And this is where we need to start saying, okay, well, there is a biological component to their biopsychosocial level of pain. And so that's where we really need to take that into account. But then we start some active interventions. A few of us might be using laser therapy. A lot of us will have heard of that previously. To give you a bit of a recap, you know, photobiomodulation therapy, photo meaning light, bio meaning body or the biological, modulate or modulation to modulate or change. And that's basically what we're doing. It's been more recently named PBMT from low-level laser therapy in the evidence and research around that 2014-15 year as well. But what it's doing is stimulating those cellular processes. It increases the ATP production and really regulates down those inflammatory mediators, starting to clear anything that's a problem there and building that you know, body part back up. That's resulting in pain relief, reduced inflammation, and accelerated tissue repair. Now, there's a whole different you know, argument on which device is better, etc. We all know mine's better, but that's okay. Knowing there's a few people in the room here with lasers and they're going, yeah, right, Kent. And that's okay, because they're all going to be doing something there, definitely. And you know, we then talk about, okay, well, what conditions is this actually going to be working with? We're talking about all biological tissue, whether that's nerve, tendon, muscle, bone, you know, a soft tissue wound, our ulcers. This is what we're working on. And if we start to look at the evidence, as I know some of us in the room have, we're starting to really see that actually we're really finding quite good improvement when used in conjunction with our standard therapies. That Achilles tendon is still going to need its eccentric strengthening, okay? What we're looking at is making sure that we're doing everything that we're already doing, but we're going to add in the PBMT to start speeding up that process. Now, in my chronic pain patients, I love this. And on my device, I've got a particular setting that is biostimulation, and it's literally doing that. It's stimulating all the biological tissues, increasing blood flow to the area to increase healing and decreasing that you know, chemically mediated neuropathic pain as well. And for those that have used the laser, you've possibly been able to find that it almost at times does give you an immediate reduction in your pain. And if your device isn't doing that ever, then mine is definitely better. Yeah, I think Erin's all over that one as well as our pain therapist. Now I've got a bit of a video here that we're going to see if we can get up. Dare I say this cool guy. This isn't going to work for me, and it's going to be Erin that's going to drag one across for us. PBMT heel pain. Everyone, talking a little bit more about
I get to have a break.
We've got a patient here that we're just doing a little bit on, so let's have a bit of a look at the screen now. We've got a few different settings for anti-edema, swelling, biostimulation to increase that healing. In this case, we're actually going into the foot because this patient's got a little bit of contracture that we're wanting to get onto. And so, you know, in this case, you know, I'm able to move sort of our Charlie head. So let's have a bit of a look at the Charlie head, pointing straight onto this patient's foot. And basically what I'm wanting to do is just have that so that we're going straight onto that foot and up, you know, that plantar fascia there as well. Sometimes I have to move a few things around to get it right. But basically then, you know, for this setting, it's a continuous pulse wave. We've got about 2.5 minutes at 100% intensity. Remember, I've talked about that 75 watts previously, really peak power, and then we're just putting that straight on at the moment. We've all got glasses, and you know, that's now treating. Now, the best thing about this machine that I think I've mentioned previously is that we've also got that handheld. And you know, on this system, I can just quickly press this one here, switches straight over to our other settings, and then I'm able to do what I need. So, you know, we've got a whole heap of different personal ones here. So I can say, okay, we want to do, you know, maybe something for pain or for, you know, a joint, and I can use that. But typically, what I find is that this Charlie head with the 3 diodes, 75 watt, is just so intense that I'm not using this as much. But think of it like a really good trigger point activator to really release that tissue. And so that's when I'll do this. This patient was on their back, and you know, maybe they put it on their stomach, I should say, they put it in a really good way, and I could then start releasing the calves through the trigger points with this, similar in those Achilles tendinopathies, and then we sort of go from there. You know, and then I might use this to really release again with that contractor to really make sure our patients respond well. But
okay, that's enough of old me. Having a bit of a chat there. Basically, what we're looking at there is sort of a very typical setting for a heel pain. You know, whether they have any, you know, neurological component to that as well, we definitely want to be treating a lot of that, you know, factor that they've come in for. It's going to down-regulate their pain signals as well. Are we able to jump out of that one?
Everyone, talking a little bit more about the adolescent age. Different settings for anti-edema, swelling, biostimulation to increase that healing. In this case, we're actually going into the foot because this patient's got a little bit of.
He's a pretty loud guy, that one, isn't he? I do love my laser. I've been using laser for about 8 years now, and it really works, particularly with our chronic pain patients. It cuts through those sort of patients that you're like sitting on and going, you know, this really isn't getting anywhere. But when it comes to my protocols, I'm very aggressive. Who's using laser in the room? A few people, yeah. And are you sort of doing 2 or 3 times a week the first week, or yeah? Because for my first week, I get them back 3 to 4 times per week. And then the second week, I'll drop down to the 2, and then the third week, typically down to the 1. That 3-2-1 approach is a really nice approach. It gets rid of all that swelling, resets those pain signals, and allows them to keep going, hopefully in a much better position, allowing them to get over that initial sort of rebound effect of what we find with their typical pain response. Now, for those that don't know me, I love my injections. I find that they're fantastic, and we don't necessarily need to be looking at steroid for that. One of the ones that I find is one of my favourites when it comes to pain and chronic pain, and a lot of podiatrists end up referring through when they're like, I don't know anything else, what else to do. This patient needs surgery potentially. Can I get another opinion? Anything like that. That's when this lift-docked prolotherapy comes in. Now, lift-docked prolotherapy is first brought about by Dr. Lift-Dock, a New Zealand pain physician, rehabilitation physician, and it's about the injection of 5% dextrose in very small quantities, but to multiple sites, which we call Valix points. Think about Valix points as being areas where the nerve bifurcates, cuts into 2, when it dives deep underneath a fascial layer or comes out of a fascial layer. And it's a really nice way to start desensitizing our nerves and giving them a little bit of nurture there, because it reduces that neurogenic inflammation, but it also in a way activates those you know, trigger points as well. But what I'm looking at here is really that decreased pain. And when I do these injections, we get a what I call an anesthetic-like response. And so I could do these points up to 3 times, after which they're typically 90% out of a reduction in pain as they walk out the door. Now, that may take 24 hours to kick in, and it may only last 1 to 2 days,
But after several sessions, 3 to 5 sessions a week apart, we then find that that chronic pain is really much more localized, getting rid of that chemically mediated peripheral sensitization and putting us in a much better position to be able to move on without all of that pain. Now, what am I doing this type of process for? All of our nerve entrapments, really effective. My heel pains, my midfoot arthropathies, any tendon injury of any variety, any adhesion or scars or traumatic injury. What type of things have I missed? Is there anything else that happens in the foot? I don't do it for bone conditions, but I do it for some of the pain associated with chronic sort of bone fractures, etc. It does work on pretty well anything. Is anyone doing any of these LiftDoc prolotherapy injections? Yeah, beautiful. And are you finding that your response to treatment's really effective?
Fantastic. So my question is around the evidence at the moment, because
Yeah,
it's not usually
that's what worried me.
first
'Cause I looked
line.
at it.
Yeah, so I don't use it as first line therapy.
Yeah.
But when
So-
other things don't work, and because I wasn't aware that the evidence was there to use it as first line.
Yeah, and
What's yours? Yeah, how do you feel?
Yeah, so I think there is definitely enough evidence to be put into the arsenal. Now, the difference is that I see a lot of patients that have already been in chronic pain for a long time that are have seen multiple practitioners. But at the same time, if someone comes into me with nerve pain that I'm looking at, whether it's heel pain, Achilles pain, and to be honest, this is the missing ingredient as far as I'm concerned when it comes to Achilles tendinopathies. This straight away, big difference, immediate after their first consult. There, to me, if I can reduce their visits coming back, and they don't necessarily need customized orthotics or to be doing eccentric strengthening for the next year, then I'm very happy to put that into place. Definitely we talk about the risks associated, very minimal risk of infection, a little bit of pain, but most patients are pretty comfortable once I talk through what we're doing, how we do it, and why we're doing it. They're pretty happy to go ahead with it. I've got no problems with it being first line. Yeah, for the right patient. Now, I'm not sure how long you've been doing it for. Yeah, beautiful. Similar to myself, I've been doing it about 2 years now, and I basically jumped straight into it after my training and am not looking back. To the point where we have some needles ready to go every single day because we do it typically most days. And so it's very quick turnover. Now, for those that are interested, I do have a course on the LiftDoc prolotherapy in about 6 weeks' time, I think it is, maybe 5.5 now. And it's just an introductory course. I don't say that I know everything, but I do think it is such a useful tool to have in your toolbox in your clinic that it's worth looking at. I know I've done a bit of training with some of you guys previously on this sort of stuff as well. Some of you in the room have had it on yourselves as well, several in the room actually. And so, it does really help kick in really quickly. I would suggest that, my results are definitely sped up. Now, we're talking about that Achilles tendinopathy and the fact that it is, to me, with laser therapy, eccentric strengthening, and the LiftDoc prolotherapy, to me, that's the recipe to get rid of Achilles pain pretty much straight away. The complications of this is particularly if it's like Hageland's deformity, bump deformity that's causing the pain, you can't get rid of that, but you can definitely localize that spread pain down into that more localized area to get rid of and reduce that a lot further as well. So big one there. Go for it, Matt.
Can I just ask the difference? So this sounds very superficial when you showed us. It's very finding those tendon points and
Yep.
working on the nerve.
It's all in that subcutaneous layer.
So my question is, instead of doing it so superficially, so say you went back more proximally and blocked the tibial nerve, for instance, I guess my question is what's the difference with blocking it so superficially, or?
So we're not necessarily looking at a nerve block, we're looking at a nerve nurturing to start to reduce those localized adhesions. So reducing any scarring, because when we have this trauma, and particularly rubbing for say the Achilles tendon, there's going to be a lot of microbleeding, which is going to cause scarring, adhesions, and that's what we're trying to free up so that those nerves can go on their normal way without too much interference. Definitely a local block's going to help. And there's some conditions, and particularly if they've got a lot of central sensitization, I find that a more local block is going to be a great one. Think about our CRPS in particular. Really nice evidence around the use of ropivacaine, a longer acting local anaesthetic, as an ankle block when it comes to managing that for a foot condition, because you're then stopping that pain and allowing that brain to sort of reset its pain signals. Again, realising that pain's not normal, that neuroplasticity we want in. Where we're looking at here is that 5% dextrose in particular has been evidenced to be nerve nurturing to increase that localised healing of the nerve, as well as desensitising the localised tissue there too.
So you put local into that as well?
No.
Sorry.
No, separate side again. Yeah, so some of my other injections that I do are like a high volume injection of, let's say 10 mils or 5 mils of lidocaine, 10 mils of ropivacaine at 0.75%, and another 15 mils of saline for injection, 30 mils total, and I can release what I need to along neural pathways with that as well. That can be quite effective in some conditions too.
So when you use the dextrose, what do you put with it? So
Just 5% dextrose plain.
That's it?
That's it.
Straight.
In 3 mil syringes in a 30 gauge needle. Yep. And that's all that we're looking at. Now, I knew all these questions would come. So let's actually have a bit of a look and see what I'm looking at. If this is going to work, it's going to be a miracle, because it wouldn't earlier. But now I want to...
Everybody, here we are just undertaking a lift off 5% dextrose prolotherapy injection.
I'm going to talk over myself a bit. These are the Valix points that we're looking at.
And you can see that I'm just lightly palpating to see where the pain is. The patient's just letting me know a little bit where those spots are as well. Now, this is a patient that had a lot of plantar heel syndrome with some tarsal tunnel, plantar fat pattern, plantar fasciitis. She's also got some cerebral nerve concerns as well as the last ganglion to her anterior ankle. She attended through my clinic on referral from a podiatrist, really suggesting that she tried everything, was getting 8 out of 10 pain to the point where she was unable to undertake activity without strapping her foot, and that's even just to take a jog for a walk in the morning. So you can see I'm just trying to find some of these Alex points here throughout her leg and her foot, ankle. And what I'm trying to do is just really find exactly where these concerns are.
So I'm going to move it ahead a little bit here. Because it is quite a long video.
So Valix point's just a point of sensitivity.
Yes, very light palpation that I'm doing here. Now this is one of the worst points that we can inject there, but is a really powerful one for releasing that plantar fascial type pain, particularly this one now looking around that Baxter's nerve area. You can see that I'm injecting about 0.5 ml or so. Now I am going to mute myself if I can.
This was a 20-minute injection all up.
Yeah, but we can see very small amounts of fluid. You can see that what we call that wheel effect, where it's sort of coming out off of the skin, and I think through this area we're seeing that. You can see that I'm actually approaching it from a distal to proximal approach, very different to what we do during a local anaesthetic type of approach. You can see that there's quite a few different spots as I'm trying to get 2 or 3 levels above our area of injury, which in this case was that heel pain in the sural nerve as well. I'm going to just push this forward a little bit. Now we'll do this up to 3 sets, so do all of those with 0.5 ml, then we'll come back and do another 0.5 ml, up to 3 times for each spot. But in between, we're going to be testing and having a bit of a feel. If that spot has been activated as such and they're no longer feeling pain, then that's where we would stop at that stage.
I'd rub that off with my alcohol wipe and then go from there. Now this patient would have had about 8 to 10 3 ml syringes to be able to provide her full treatment. Sounds like a lot. It's not overly. Now you can see quite a lot of swelling around that sort of perineal tract, that sural nerve. This worked out very well for this patient, which we'll see in a moment. Now this is how I'm testing them there. Sorry, it's on a GoPro, so you can't constantly see. Just very light touch is what I'm doing there. If they're activated, I'm going to wipe that off. And you can see that, yeah, I'm starting to rub a few of those off with my chlorhexidine in this case. Yeah. This is our patient just going for a bit of a walk now, having a bit of a feel, because I think it's always really nice to then be at the end saying, okay, great, let's have a bit of a walk around, let's see how that's feeling. Hopefully much improved. Like I said, typically we'll have a 90% reduction in pain, quite often 100% reduction. And again, we're going to be really nurturing those nerves and ligaments so that we're in a much better position. This patient wasn't able to stand on one leg prior, was able to afterwards. So they were pretty happy with that, as you can see. Yeah. Beautiful. Now, strength and conditioning. Sorry, physios, I'm going to jump in on you here. I think Tula sent one through yesterday that was fantastically provided appropriate exercises. Yeah, go for it, Ella.
Go back to the other, the needling. Sorry, because some of those points you can, for like dry needling.
Yep.
And I understand that you don't get the nurturing effect, but is that something you have researched? Is it, because I could imagine it's a similar...
Yes, and the local trauma due to the needle going in is a part of what I feel definitely works when it comes to the lift-docked prolotherapy. I definitely agree there. I also agree with the use of the laser therapy in addition that it is a really nice approach to make sure that patients are getting good chemical mediated response from the laser as well as from the prolotherapy.
What would you do first, Ken?
We, depending on pain's levels and openness to go to injections, I'm very commonly putting both into place at the same time. Again, a lot of my patients are coming having already exhausted a lot of more conservative options, but that doesn't typically change my approach to patient pain. If I feel due to their symptoms in particular, so if they're more burning or non-localized pain, I'm more commonly going to be going for the lift docked in addition to the laser. Otherwise, if they're not keen or they've got symptoms that I'm like may or may not respond, then I'll say let's do some sessions of the laser. Let's do 3, 4, 5 sessions of that, and then let's touch base and see how we're responding. If we're not, then I'll go to this.
How many times a week would you do that? Just the once?
Yeah, one for each patient, once per week. Yeah, for 3 to 5 weeks, if required. If their pain significantly drops off, like there's some of my patients that I do it once and then I don't see them, you know, for 6, 12 months. Typically it does work ongoing, and they're very rare patients. I'm sort of talking, you know, count on one hand. Most patients will respond quite well after 2 to 3. Some I will do 5. Very rarely do I do more. And again, those patients I can probably count on one hand. Yeah. Any further questions on the lift dock? No, these are great questions. And this is what the beauty of being in person is, that we get to ask these questions as we're going. I think that's very valuable.
I mean, if you did both on the same treatment, would you laser and then...
Yeah, so we do laser and then the lift dock. Definitely Erin's more likely to be on time than me. Although I'm not too bad at the moment. Where people would then say is, okay, where do you put shockwave into it? Again, we're doing the laser potentially several times a week. You might look at the shockwave in addition if you're really wanting to cut through, but I'm not using as much shockwave at the moment as I am for just the laser therapy because Erin does such a...
They opt to have the laser first before the
Yeah.
Yeah, they just think it makes feel that, yeah, it feels better. Right.
Yeah.
Oh,
Yeah.
it's really
Yeah. Yeah.
easy. It's easy.
But even on the same day that they're both doing that, they'll do the laser and then they'll do the lift docked prolotherapy because it doesn't hurt as much. Again, knowing that the laser and we've got a pain down regulator as part of that as well. I think we've heard enough from him. Some exercises, and I think strength and conditioning is really important, and that's why I wanted to mention it, but I didn't talk about it in too much depth here. But I think all of our patients need to keep moving, and it needs to be made sure that they're doing it in a really nice way. And I'm a really big one for drop your reps, but let's do that as precisely and effectively as possible. Now, for me, I'm a big intrinsics man. I love them. My biggest thing, and I put down the bottom here, linked to that behavior or a physical prompt. Behavior for my intrinsics is I get my patients to pick up their socks or their shoes when they put their shoes on each day. Now, that might mean that they're doing their intrinsics once or twice, hopefully twice per day. So when they're putting their shoes on and taking them off. And I think that's a really nice way to make sure that they're doing them. And I say, every time you put your shoes on, remember me, remember that you should be doing your exercises. So, and then I'll talk them through it and I'll say, clench 2, 3, 4, and then flare 2, 3, 4. I want them to do that really nice and slowly, really purposefully. I want them to be thinking about it as we're talking about it. Now, a lot of people will say, we only really need that for forefoot conditions. Definitely people have great responses, say for their plantar fasciitis, when we're doing that intrinsic strengthening as well. I pretty much recommend that for every single patient because it does do a lot of good generally for their stability and strength, their proprioception, for some of my patients that are going through for forefoot surgery, any prehabilitation we can do is always a good thing. Now, when we do our heel raises, and I say done properly, I think we've all seen those people that go like this and have a nice bounce. I'm not a fan at all. We've all seen them. And I talk about a count to 8 going up, and that's a very slow count to 8. And then a count to 12 going down. That extra 4 is on the step as they're dropping. I tell my patients to always wear their shoes with their orthotics and definitely their most supportive shoes because I want them in a neutral alignment so that we're activating that gastrococceleus neutrally. And then I want them to be doing, even if it's only 3 to 5 repetitions to start with, but I want them holding on and building up. There was some great research, and I want to say it was around 2009, of pre-point dancers having to do 30 double heel raises before they could transition to single. And I'm just like, okay, well, that's pretty much gold standard for me at reducing ankle sprains and injury that way. So I tell my patients do 30, build up slowly to being able to do 30 of the very slow heel raises, holding on, and then not holding on, and then you can start holding on and doing single leg raises as well. I sort of go that way. I know not everyone might be the same inclined, but I think it's a really important way to get that. Now, the other thing that I say to my patients is that we want to keep that foot really nice and straight. And so I literally point and say, okay, give me your foot. And I point from your second toe to the center of your ankle, to the center of your knee, to your hip joint. We don't want that line to break. And so that means when we're going up, we're not shaking, we're not dropping out into inversion, we're not seeing those knees knock or anything like that. And that's just that memory point to say, okay, is the line straight? Beautiful, I'm doing it properly as I'm holding on. And having those really nice cues is a great way to go. Now, when are we doing our heel raises? We do this a lot with our kids of when we go down this hallway or when we go underneath this arch. I want you to think about doing that, whatever it might be. For me, I say with my heel raises, every time you open the fridge, I want you to hold onto the fridge and then go up and then down and even just do the one, but you're going to be opening that fridge a fair few times. If they want to link it into some other activity, then great, let's work towards that. And I think that's a really nice way to say, okay, yep, every time you go under that archway in your house or down that hall, at the end of the hall, that's what you're going to be looking towards. Proprioception. Physios, please jump on in.
Typical balance exercises and functional activities are going to be great. I'm a real big one for the massage and movement being a key part. We're talking about our patients with CRPS and fibromyalgia and really wanting to desensitize this area. We can't do that without some massage of that area, without touch, without feel, without retraining those nerves. As soon as we realise those patients that may have CRPS or fibro are in that case and in that area, and that we exclude any physical injury, definitely we want to be all hands-on, we want to be moving, we want to be getting going again. One of the things that I find is fantastic is taping with hyperfix. And what we're looking at there is reactivating all those nerves because of a lot of touch and really starting to get those nerves firing in a way that the ligaments would otherwise have, because we're getting some of those stretch receptors as well as of our free nerve endings causing pain, as well as our pressure regulators in that area as well. Hyperfix, for those that don't know, it's a little bit more stretchy than your typical medical tapes. Now, it's not as stretchy as our rock tapes, and you know, I sort of look at our sports tape as being something that we use for our sports game. After the 90 minutes, we basically lose the strength of that stability. Great, we've got it on, it's doing a similar thing to the hyperfix afterwards, but I just find that hyperfix is a really nice in-between. Now, what do I do with it? I literally just do a stirrup. Very straightforward, but it means that the patients can actually simulate this, and it's probably one of our biggest sellers as far as, well, it is our biggest seller as far as products, because patients, as soon as they put it on, and I do this for pretty much all of my patients, they put it on their foot and they stand up and they go, wow, that's 50, 60, 70% better already. Now, that's not just because of the tape, that's because I've reassured them, I've given them a plan, I've given them a diagnosis, but I think it's a really powerful way that we can then tie that all in, give them some support, give them some further proprioceptive feedback, and really make it a really nice way for the patient to get some response. Now, hopefully this one works for me. Do you want to just try clicking the screen and we'll see? It's hiding. Oh. It's because we've got that, even just try clicking that screen. Oh, different one. She's really good at technology. No, we're on proprioception now.
Wrong one.
So what we're seeing here is that I'm doing a stirrup, putting it on, nice lateral load in there, having a really broad area, and then pulling it off. Now, we're seeing a lot of Liz Frank injuries at the moment as well, and so that medial one I might pull a little bit more over that first TMTJ, but it's a really nice way to sort of get us into the right spot there as well. Hopefully there's a play button. I think that's a pretty simple taping response or approach that we're all doing. Try it on some of your patients. You'll be surprised how well that it works. Just click. Yeah, click on it. Beautiful. Now, our psychosocial approaches. This is sort of tying it all back in together now, because what I really want us to do is start considering, you know, some very minor cognitive behavioural therapy, and this is something that is a psychology-based term. Who's heard of cognitive behavioural therapy, CBT? Yep, beautiful. It's a really good thing that we need to be aware of. You know, it's restructuring of how we're thinking, how we're talking, how we're behaving. Okay, so it changes those negative thoughts into more balanced and realistic ones. You know, and that's why I'm really big with my SMART goals when people come in. So straight away, if they're thinking they're going to be running marathons, I can knock them down a peg and say, actually, let's be realistic about this. You can't walk 100 metres right now and you've never done a marathon. We want to make sure that we're on the same page and being realistic about that, because we all have those patients come through. But then we also want to have that behavioural activation, okay? That is going to mean that our patients are scheduling and are engaging in those enjoyable activities, and, you know, talk to them briefly about this as we might be undertaking other treatment, so that they've got those goals of, oh, well, what did you used to do? How about just going down to the local bowls lawn and having a bit of a chat, and then how about, you know, you have one play and all of a sudden the endorphins all kick in and they're moving in the right direction. That gradual exposure is really important in these cases.
And we know that ourselves, we've all been in pain. We all know that we need to do a slow, push back into our normal activities. We see this a lot now in our work cover cases. We need to be really aware that, okay, we want to get people back into their work, even if it's at a limited capacity, as soon as possible. And that might mean just attending work and getting that social side of it, as well as just a little bit of hands-on. Of course, refer for your psychology input. Okay, I'm not saying that we all need to be psychologists, but we should have a bit of an understanding, be able to lead our patients down the pathway of getting that support. A lot of people still do have that stigma around it, particularly our older gentlemen. We need to be aware and support them through that and say, these sort of things, can be helped quite easily, and pointing them towards their GP to start those conversations as well. But also start challenging those negative thoughts. Question the accuracy and helpfulness of those thoughts with them and say, well, cutting that limb off is not going to be the answer. That's not going to help what we're looking at. But here's some other ways that we can potentially help push you in the right direction. Change the I can't to I may need to adjust my activities. Okay, those type of things, or I can do this, but I'm not yet able to do that. And that's where I want to be. And so give them that guide and that direction and change the language, which again, I really love that neuroplasticity around this, is what we're really changing so that we can change their behavioural thoughts and therefore change everything ongoing as well. Curable. Anyone heard of Curable? Yeah, beautiful. Some of us. This is a cognitive behavioural therapy app. It's free for the first month for patients. It's free for practitioners to go through and look at their resources. I think once you get it online, it's about $9 a month, I think, somewhere around there. It's not much. It's got a lot of great resources on there. There was a time there where I was pretty much signing all of my patients up onto it because it gives such a good understanding of pain and guides them through that pain understanding and process so that they can start saying, okay, well, what's potentially happening here? How can I potentially get some further assistance in understanding pain and understanding how it looks at? They've got a few different modules that you can go through at your own pace, and you can do that as a practitioner as well. What's next? The sneak